We have here is a patient. She is 66 years old. She comes in for a sore throat. If you look at the moderate column here, what we have is no HCCs reported. So demographic is 0.299 for this member, no HCCs, and then we have that diagnosis code of 462 for a sore throat or pharyngitis. The total RAF, risk adjustment factor, for this patient is $215.70 a month is what CMS is saying that it's going to cost the health plan to take care of a member at this age. If you were just to add in the status of uncomplicated or asymptomatic HIV, which is code V08, that will add 0.945 to her total risk score. The total risk score then is 1.244. In dollars, we have $897.43 a month. That is a 76% increase, and it's about 10 grand a year, just based on that one code being reported at some point during the calendar year, or even during this acute visit. So other aspects of coding that I'd like to touch on, there are really three coding tips I have here. The first one is coding accuracy. I know that you've probably heard this from your coders in the past, but coding to the highest specificity is very important, not only on the provider side, but also on the health plan side. An example of this would be a patient with controlled diabetic neuropathy. What we generally report for diabetes is 250.00, but if they have a neurologic manifestation, that then changes that fourth digit from a 0 to a 6, and it increases the risk adjustment factor tied to it. So the sicker the patient, or the more manifestations they have, the higher the risk adjustment factor. In addition to that, for this patient, we would also need the diagnosis code for the neuropathy. A lot of times providers think that because you're clicking that 250.60, you're catching diabetic neuropathy, when the nomenclature for diabetic conditions with a neurologic manifestation isn't telling that whole story. There's the 357.2, which in the nomenclature is for diabetic neuropathy. Good news for 2010, this is going away. So for 2010, diabetic neuropathy is going to be one code. So you won't have to do as much of the dual coding. In fact, in diabetes, there's only 3 situations where you'll have to report more than one code for diabetes with manifestation. So that's going to be really nice. The second coding tip that I'd like to give tonight is precise designation. So the example I have here is a patient that has had a stroke. So the initial hospital encounter is going to have that CVA coded. When the patient comes back for follow-up in the provider's office, that CVA is no longer an acute CVA. The patient now either has one of two things. They have a history of CVA, or they have residual effects caused by a CVA. So we want to make sure that we're not using that initial CVA code every single time the patient's coming into the provider's office, because that is increasing the risk score. So let's say they had their CVA in December of 2012. They come to the provider's office for a follow-up in February of 2013. The provider uses that